Well, hello, everyone. This is Neil McIntyre. I'm from Duke University in Durham, North Carolina. My good friend and colleague Talal Dahan has asked me to maybe update everybody on our current thinking in optimizing lung protective mechanical ventilation. I'm going to try to do this with some caveats related to the current COVID-19 viral infections / ARDS, but this is a constantly evolving field. And as I told Talal, this may be the first of several presentations I'd like to give as we learn more about this. Again, though, this is a basic construct as to how we want to protect the lung when it is severely injured. So what I want to do over the next 45 minutes or so is talk about dynamic stress and strain at end inspiration, during the tidal breath, and end expiration. Some of the next steps that might be considered if we have maximized our protective strategies. And then, as I say, I'm going to add my current thinking on COVID-19 caveats, which, as I say, could easily change day to day or week to week. So let's look at minimizing static and dynamic stress and strain. And underlying all of this is ventilator-induced lung injury and the three major mechanisms we think about today. This is the pressure volume curve, excuse me, of the human lung that is injured. The light blue curve is the sigmoid shape many of us are used to looking at. On the vertical axis is volume, which engineers refer to as strain, and on the horizontal axis is transpulmonary pressure, which engineers might refer to as stress. In essence, stress is a force on an object, and in the lungs, of course, that's the pressure we put across alveolar structures. Strain is the deformation of that object under stress, and in the lungs, that would be the volume change that occurs as we apply the stress or the transpulmonary pressure. As you look at this curve, you realize there are three areas which are likely sources of injury. At the upper right is excessive maximal stretch, what some people call static strain. And this occurs when the transpulmonary pressure across alveolar structures exceeds 30 centimeters of water. At the bottom left is a second injury, a collapse and reopening phenomenon. It's not the collapse itself, it's the repetitive opening and closing of a unit that causes a strain injury. And then in the middle is tidal stretch. And this occurs even if there's no excessive maximal stretch, and it occurs even if there is no collapse and reopening. It occurs when the tidal volume exceeds the normal human maximum, which is up around 7 or 8 milliliters per kilogram ideal body weight. So I want to look at these three mechanisms separately. First, maximal stretch, overdistension. Again, we're talking about a transpulmonary pressure across alveolar structures. And if you and I take a deep breath right now, and we measure the pressure across our alveolar structures at total lung capacities, it's about 30 centimeters of water. And we've known for decades that if we exceed this, we run the injury, or we run the risk of tissue injury at modest elevations and actually lung rupture, interstitial emphysema, and pneumothorax at higher levels. How do we assess this risk? How do we measure transpulmonary pressure? Well, in today's technology, basically what we can measure in terms of pressures is circuit pressure, pressure on the far left on the endotracheal tube going into the lung. Some ventilators give us the opportunity to measure tracheal pressures. I've not found that particularly useful. And then if we stop flow so that there's no flow-related pressures in the system, we can estimate alveolar pressure from the circuit pressure. This is the so-called plateau pressure under no flow conditions. A pressure we'd love to know is the pleural pressure on the other side of the alveolus, because the transpulmonary pressure is what's injuring the lung, and we can only guess at what the pleural pressure is. Fortunately, in normal chest wall situations, the pleural pressure is relatively low, so our alveolar pressure, our plateau pressure, is a reasonable estimate of the transpulmonary pressure. So let's talk about this plateau pressure for just a moment. I have 4 breaths here. Breath A is a pressure assist control breath. Breath B is a pressure assist control breath. Breath C is a volume assist control breath. And breath D is a volume assist control breath. And as you can see, I plotted pressure, flow, and volume. So the question, which of these 4 breaths, and there can be more than one, can you actually measure a plateau pressure off of these displayed graphics? Think about that for a second. The correct answer is actually in breath B and breath C. And the reason you can measure a plateau pressure there is you'll notice on breath B, at the end of the breath delivery, there's a short period where there's zero flow, no flow. And that means the pressure in the circuit up at the top is equal to the pressure in the alveolus. Breath C has the same thing. Notice there's a short pause, and during that pause, the airway pressure drops a little bit because there's no more flow-related pressures. And again, we have a plateau pressure, a pressure estimating alveolar pressure. Breath D does not have a pause, and therefore the pressure in the circuit does not equal alveolar pressure. And breath A also does not have a pause, and we can only guess at what the plateau pressure might be under these conditions here. The point I'm trying to make here is that plateau pressures can be measured in both volume control, volume assist control, and in pressure assist control if you put a pause in. And most modern ventilators allow you to make such a pause. I'm going to be talking about plateau pressures a lot during the rest of my presentation, and understanding how to make this measurement, I think, is critically important. And I'll try to explain why as we go along. So again, the key measurement we're looking for is the transpulmonary pressure, the pressure across the alveolar structures. And it's that plateau pressure minus whatever is in the pleural space, which again, we can only estimate or guess at the present time. Here are displayed graphics of flow, volume, airway pressure, and esophageal pressure. I'm showing you esophageal pressure because that's a rough estimate of what the pleural pressure is. We don't routinely put pleural pressure catheters in, but if we were to, this is what it would look like during a controlled breath. So again, I have a pause during the flow at the end of inspiration, and as a consequence, we can measure a plateau pressure, which in this example is 30. And because the lung is pushing the chest wall out of the way and the chest wall compliance is not too bad, only 10 centimeters of water is generated in the pleural space. The transpulmonary pressure is that 30 we measured minus the 10 that's down in the esophageal and pleural space, a transpulmonary pressure of 20. And remember, it's the transpulmonary pressure that drives the stretch and the potential for injury. So we want to limit maximal stretch. If the pleural pressure is low, a normal chest wall, the airway pressure at end inspiration, the plateau, is a reasonable estimate of the transpulmonary pressure, as I mentioned before. We run into trouble when the pleural pressure is high, a stiff chest wall, somebody who has surgical bandages, abdominal compartment syndrome, or as we see increasingly, obesity. Under these conditions, this can stiffen the chest wall, and thus the plateau pressure includes both the pressure to push the lung out and push the pleural pressure or push the chest wall out. So I have a little example here. In both examples, I put in 33 centimeters of water. 33 centimeters of water is delivered to the alveolar space. In the left panel, you'll notice that the lung is quite stiff and that most of this pressure is dissipated trying to expand the lung. The chest wall is very compliant. Only 5 is appearing in the pleural space. On the right, we've got the opposite, somebody with a very bad chest wall. In this case, the 33 centimeters of water, not much of that pressure is needed to distend a compliant lung. Most of that pressure is being used to expand the chest wall. And our transpulmonary pressure here is only 8 centimeters of water. So I want to reemphasize, we want to keep our transpulmonary pressure less than 30. Pressure is distributed uniformly throughout the lung, and that means that there really are no alveoli exposed to excessive stretch when we keep the transpulmonary pressure less than 30. This also means that if we have somebody with a chest wall problem, we can push that upper limit of plateau pressure above 30 to account for the fact that the chest wall is driving some or a lot of that pleural pressure or plateau pressure. Effort always confuses this measurement because a patient can generate negative pleural pressure. So on the right, I've got a passive breath, 30 centimeters of water, and this is a compliant lung, or actually a fairly stiff lung, sick lung. But what I'm trying to illustrate here is that with the pleural pressure at only 5 centimeters of water, the plateau pressure of 30 is very close to the 25 centimeters of transpulmonary pressure. The patient on the left, however, has a negative 10 centimeters of water being generated by the effort, and this creates a transpulmonary pressure of 40 centimeters of water, even though our plateau was only 30. So to sort of summarize, if the chest wall is stiff, it's going to cause the plateau pressure to overestimate the actual transpulmonary pressure. And if the patient is active, it means that the plateau pressure is probably underestimating, if you can even get a plateau pressure in an active patient. It's underestimating the actual transpulmonary pressure. So again, to sort of summarize, we want to keep the transpulmonary pressure below 30. With a normal chest wall, that means keeping the plateau below 30. With an abnormal chest wall, a stiff chest wall, we probably can raise that plateau pressure threshold as much as 50 or even 100% if we need to. Okay, let's look at the middle one here, excessive tidal stretch. So the goal here is to keep the tidal volume less than 8 mLs per kilogram ideal body weight. The range in the ARDS network study that is driving a lot of this discussion was 4 to 8 mLs per kilogram. But this is not as simple as just ideal body weight because ideal body weight assumes that the functional residual capacity is near normal. What if it's not? And indeed, in our sick patients, it probably clearly is not. So I have two examples here. On the left is a patient with significant injuries at the bases, but the tidal volume is distributing to 80% of the lung there. If you give a global tidal volume of 6 mLs per kilogram ideal body weight, this translates in this example into about 7.5 mLs per kilo regionally. The real problem comes in on the right. Where we have the infiltrates occupying the majority of the lung. And the only functioning lung is that left upper or that right upper quadrant there we see. And only 22% of the lung. And under these conditions, 6 mLs per kilogram ideal body weight translates in regionally into 27 mLs per kilo. So how do we address this? Are there better ways to scale tidal volume? And imaging would be the ideal thing. CT scans, but we don't have CT scans readily available in our ICUs. Technology that's kind of interesting and is becoming available around the world, we still don't have it in the United States, is electrical impedance tomography. And there's an example there. This involves putting 17 electrodes around the chest and then putting small currents of electricity across the chest and measuring the electrical impedance. And you can get an image much like you're seeing on that screen there. And in this example, we've taken the lung and divided it into 4 quadrants. And as you can see, we can look at the regional tidal volumes in all 4 of those quadrants, as well as the global tidal volume up at the top. So this is exciting technology. Unfortunately, we're not there yet. We could measure FRC directly, but this is very technically complicated. What I think is becoming an increasingly valuable tool is to look at what's called the driving pressure to scale tidal volume. So what's the driving pressure? So here's my example again of flow, volume, airway pressure, and pleural pressure. And again, I have a plateau pressure of 30 in this example. And the driving pressure is simply the plateau pressure minus the PEEP, In this example, that's 30 minus 0 for a driving pressure of 30. So why is the driving pressure a useful tool? Because the driving pressure actually allows us to scale the tidal volume to lung compliance. The driving pressure is tidal volume divided by compliance. So instead of using ideal body weight in the denominator, we might want to use compliance in the denominator as a reflectance of how much viable lung is being actually ventilated. So again, I go back to my examples I showed you before. Here we're giving an example A, 6 mLs per kilo, evenly distributed. The driving pressure in this example would be only 8 centimeters of water. In contrast, where we have a much smaller baby lung, 6 mLs per kilo will overdistend that healthier region up there, and this will create a driving pressure of 22 centimeters of water. So again, what am I suggesting here? Driving pressure is tidal volume divided by compliance. Compliance is a surrogate for lung volume, and therefore perhaps we should scale tidal volume to compliance rather than ideal lung size. In my examples here, you would leave A alone, and you would be advised to reduce the tidal volume further in B. So what's a safe driving pressure? Well, that we really don't know. Nobody has actually studied driving pressure as an independent variable. This is a summary of studies looking at driving pressures in a variety of randomized trials evaluating PEEP strategies and looking at driving pressure along the horizontal axis and mortality risk along the vertical axis. As you can see in this conglomeration of studies, it looks at somewhere around 15 centimeters of water might be a threshold where the risk of death goes up. So at least for the time being, a driving pressure somewhere around 15 is considered generally to probably be in a safe range. Again, this is something that's being constantly studied and updated, and we may have different recommendations in the not too far different future. So again, you want to keep your tidal volume at less than 8 mLs per kilo of ideal body weight for sure. And depending upon your driving pressure, you might want to reduce it further. Let's look at collapse reopening strain. And this is a simple cartoon that I'm sure all of you are familiar with, the basic principle behind PEEP. And that is you have an alveolus that opens and then closes and opens, and then you prevent it closing with expiratory pressure. And the good news is you prevent de-recruitment and collapse. The bad news is in healthier lung units, you may overdistend them with unnecessary PEEP. So this is the conundrum we always face with PEEP. PEEP is a two-edged sword. By preventing collapse and reopening, it reduces lung injury, improves mechanics, and increases aerated lung regions. This is good. However, if collapse reopening is not occurring in healthier regions, it can overdistend already aerated regions and increase injury, and that's bad. So how do we balance these? Again, I go back to visual tools, and Dr. Gattinoni has made a career out of using the CT scan to appropriately titrate PEEP. But like I said, we are not so fortunate to have that kind of technology readily available. I refer back to the concept of electrical impedance tomography I described before. And in fact, it may be helpful here too, looking at regions that collapse and reopen, looking at regions that overdistend, allowing us to visually set a balance. Some people like to use pressure volume curves and look for best compliance. I find these very difficult to do and cumbersome and often quite difficult to interpret. And as a consequence, most of us are using what we call PEEP FiO2 tables, which are empiric attempts to try to balance the good, PO2, with the bad, plateau pressure and excessive FiO2s. So this is an example of a PEEP FiO2 table. These were two used by the ARDS network back almost 20 years ago now. And these are very simple concepts. You have a target of recruitment indicated by a better PO2, 55 to 80, and you have a target of potential harm, a plateau, which we like to keep below 30. Maybe we can push it to 35. So with those two goals in mind, we then can create a range of PEEP and FiO2 arrangements. Look at the blue curves for starters. This was the original table. It had a minimum of 5, a maximum and a minimum of 30% FiO2, and it goes all the way up to an FiO2 of 100% and a PEEP of 24. Where did the PEEP of 24 come from? It was selected as a potential maximum because it still gave you 11 centimeters of water to drive a tidal volume and keep the plateau pressure less than 35. It looks somewhat linear. That is not evidence-based. It's expert opinion, but it's something easy to use. The red or orange bars, it's a similar PEEP FiO2 table, but it's more aggressive with PEEP. 12 centimeters of water with other parameters being similar. Again, the way this works is if your PO2 is less than 55, you move a step to the right. If your PO2 is less than or over 80, you move a step to the left. If your plateau pressure is above 30, maybe 35, you move a step to the left. And you keep doing this until you get as close to this table as you possibly can. Do these tables work? Well, they are easy to operationalize. Is the blue table better than the red table or vice versa? Well, that's a trickier question. It was interesting, and also there were three major studies that looked at these different approaches. One was done in Europe, one was done in Canada, and the original one was done with the ARDS network. And individually, these studies didn't show much difference in mortality outcomes. What was interesting is when these were all pooled, all three of these studies combined, and patients were broken into those who were sick or sicker, with a PDEF ratio less than 200, the patients with ARDS as defined back in the 2000s on the left, and patients not so sick, PDEF ratios above 200, the panel on the right. Today, we would call these moderate and severe ARDS on the left, a mild ARDS on the right. What I'm trying to show you here, though, is that if you break it out this way, the high PEEP table actually had a mortality benefit in the sicker patients. And the exact opposite was true in those without ARDS, or excuse me, with mild ARDS, a PDEF ratio less than 200, where the high PEEP strategy trended towards a worse outcome. And if you think about it, this actually makes a lot of sense. If you have a lung, like in the upper panel there, with not a whole lot of inflammation, and you push a high PEEP strategy on that lung, you may just end up not recruiting very much, and in fact, only serving to over-distend the healthier regions of the lung. But the opposite is true with our lung that has extensive injury, the one on the bottom, where the beneficial effects of lung recruitment and preventing de-recruitment of PEEP outweigh the potential harm in over-distending the healthier regions of the lung. So at least today, I think it's reasonable to think of your sicker patients needing the higher PEEP table and your not so sick patients needing the lower table. I'm going to come back and comment on that a little bit more in detail when we address the issue of COVID-19, but at least as a broad principle, I think these are valid concepts. So again, PEEP FiO2 tables, balancing adequate PO2 against FiO2 and over-distension. I want to return to the driving pressure here, because remember, driving pressure, tidal volume divided by compliance. I talked before about fine-tuning the tidal volume, reducing the tidal volume to reduce driving pressure. But if you think about it, maybe a little extra PEEP might help also reduce the driving pressure by improving compliance. This is very difficult to predict, and often is a trial and error exercise. You add a little PEEP and you look what happens to the driving pressure. And if it got better, you did the right thing. If it got worse, you did the wrong thing. Trial and error. A comment about chest wall and PEEP and the PEEP FiO2 tables I showed you. Again, if you've got a very, very stiff chest wall, creating lots of pressure, even during expiration, you may need additional PEEP than what these tables are recommending. And again, this extra PEEP can be guided by raising your plateau pressure targets above 30 to maybe 40 or even 50 in the very, very stiff chest wall patient. So before I leave this basic discussion, I want to talk about the stress index as another way to sort of fine-tune your settings. So what is the stress index? The stress index is really a pressure volume curve during the tidal breath at a set PEEP and a set constant flow. So let's look at that definition for just a moment. Why do you want a constant flow? You want a constant flow because you want to eliminate the effects of pressure, flow-related pressures on your pressure profile. So you want a constant flow, and ideally you'd like a lower flow, down in the neighborhood of 20, maybe 30 liters a minute flow. So you use a volume cycle breath with whatever tidal volume and PEEP setting you are using. So if you're in pressure ventilation, that's fine. You just temporarily have to turn the patient into volume breaths with the same tidal volume and the same PEEP. Again, use a constant flow to minimize any flow-related pressures. And then, as I say, ideally, it's nice to reduce the flow as well. And then what you're looking at is the shape of the pressure waveform over the breath. That solid part of the curve indicated on the pressure profile. So what are we really doing? We're looking again at the pressure volume relationship during the tidal volume at the PEEP you have selected. So, for example, if that curve bends upward, you'll get a curve that looks like this. And this suggests that you need more PEEP. This suggests you need more PEEP. If it's a straight diagonal, that's the sweet spot. That's where you want the patient to be. And if it bends upward, this suggests you either need to reduce the tidal volume or reduce the PEEP. You are over-distending the lung. These stress index numbers are the exponent in the equation that describes this pressure profile. If the exponent is 1, it means it's a straight line diagonal, as in the middle breath. If it's less than 1, it implies the curve is bending in that shape that you see on the far left. If the stress index is greater than 1, it's indicating again that the curve is bending upward. So this is how one might use a stress index, again, to fine-tune your ventilator settings. Just to show you this works in real life, this is an animal study John Davies and I did a few years back, looking at the stress index while we titrated PEEP. And again, I have pressure and flow over time. As you can see in the top graphic, the curve is bending in a concave sort of fashion. It rises quickly and then the rise slows down. And this is, again, indicative of under-recruitment. In the middle, we have a straight diagonal, and that's the sweet spot. That's where we want it. And on the bottom curve, you'll notice with excessive PEEP, we are over-distending these sets of lungs. So it can work, and it's a nice tool to use when you're trying to assess the mechanical effects of your tidal volume and PEEP setting, and perhaps helps you to titrate those settings a little bit more rationally with regards to lung mechanics. So let me sort of summarize this part 1 here. We want to keep lung static strain minimal. The end inspiratory transpulmonary pressure estimated by the plateau pressure with a normal chest wall and no effort should be less than 30. Again, this limit might be driven higher, up to 30, up to 40, maybe even 50 in the patients with the very, very stiff chest wall. The lung dynamic strain, you want to keep the tidal volume less than 8 mLs per kilo ideal body weight. And I think it's a good idea to maybe fine tune this with either the stress index or driving pressure and perhaps reduce it if needed. And again, PEEP FiO2 balanced. I like using the PEEP FiO2 tables. Fine tune these with a stress index or the driving pressure. So the general principles of managing the sick lung with parenchymal lung injury involve these three principles. How are we doing? How are we doing on this? This is the Lung Safe study. This is an interesting study that measured ventilator parameters in almost 3,000 patients on a single day around the world, looking at tidal volumes, looking at plateau pressures here. And as you can see, the world does pretty well with tidal volumes. Most of the time, it is less than 8 mLs per kilo, but you will notice that as high as 30 or 40% of the time, tidal volumes are probably still excessive. So we have some work to do here. With regard to plateau pressure, we're much better. As you can see, the vast majority of patients are taken care of with, are being managed with plateau pressures in what you might consider a safe range. How about with PEEP? This is kind of interesting because you will notice the ARDS suggests PEEPs as, that can go as high as 20 centimeters of 24 centimeters of water. In the ARDS studies, by the way, the low tidal or the low PEEP strategies generally ended up with an average PEEP of around 9, and the high PEEP strategies ended up in around 14. So as you can see, the practice around the world doesn't look like it's following that trend. There appears to be perhaps underuse of more aggressive PEEPs, perhaps in the right patients, and there appears to be a very cautious underuse of PEEP in many of these patients. Again, this is speculation on my part, but it is interesting how the world is behaving. Notice the world is also comfortable going up to about a 60% FiO2 in using these various PEEP settings. But you will also notice that as high as maybe 30 or even 40% of the population is being exposed to FiO2 levels greater than 60%. So that might lend argument to the fact that maybe we are under PEEPing a number of patients. I think it's always important in talking about lung protection to realize that there are trade-offs. This is the original ARDS network study, 6 versus 12 mLs per kilo tidal volume. And it's looking at P to F ratios, PO2 over FiO2 ratios over the course of the study. And what is really interesting here is you will notice on day 1, the P to F ratio is markedly better in the high tidal volume group. The high tidal volume group. That's the group that goes on to die. There's a disconnect here in physiology versus outcome. What's going on here? Well, I think what's happening is on day 1, in the high tidal volume group, there was more recruitment that took place with the higher tidal volume. And that, for at least a couple of days, improved gas exchange. But if you recall back the slides I've shown you earlier, these excessive tidal volumes were probably over-distending the healthier regions of the lung, and as a consequence, producing injury. And this injury rears its ugly head on day 3, such that the curves actually reverse on day 4, and the high tidal volume group goes on to die. So I think this is an important point as we look at strategies and how to manage patients, that we be always careful of relying too heavily on physiology measurements, compliance and PO2. Obviously, they're important, but always remember that at the end of the day, what may give a transiently better blood gas or compliance measurement at the end of the day may produce injury in these healthier regions of the lung and thus a worse outcome. So the last few minutes, I want to talk a little bit about COVID-19 and what we're learning. I think the principles I've already talked about apply to COVID-19, but there are some interesting caveats. Oh, I almost forgot. There are some, I'll come back to COVID in just a second, my apologies. There are some things I think that can be done as an adjunct to our ventilator strategies. The supine position, I think, can really have some significant benefit. It really can open up much more aerated lung in these patients with significant lung injury. And I think you all know that in the patients with severe ARDS or moderate to severe ARDS with P to F ratios less than 150, going into the prone position for 16 hours a day really did improve outcomes. Neuromuscular blockers are controversial. They do reduce oxygen demands. They eliminate asynchronies. And this original study from Papazian suggests that that may translate into a better outcome. The more subsequent study done by the Rose study in the United States suggested that maybe routine neuromuscular blockers are not necessarily life-saving. Having said that, I do find neuromuscular blockers important in patients who are difficult to synchronize, patients whose oxygenation is really terrible and in whom I want to reduce oxygen consumption. You run a risk, of course, with neuromuscular blockers of ICU weakness, but again, when you're with life-threatening hypoxemia, I think it's probably worth the risk. How often are these strategies being used? Interesting, this is also the lung safe study. Neuromuscular blockers in the more severe ARDS patients were used about 37% of the time in this survey of around the world. Prone positioning, interestingly, is only 16% of the time. I think we have opportunities to improve, especially with the prone positioning. And then finally, VV ECMO. I don't have time to go into VV ECMO. You all are experienced ICU docs. You know about VV ECMO. It facilitates lung protection. That's its main goal. Facilitates lung protection by reducing the need for mechanical ventilation. There's nothing curative about ECMO. It buys time, helps you protect the lung better. Oxygenation depends on circuit flow. This current VV systems that most of us use can only handle about 75% of the cardiac output, sometimes not even that much. And thus oxygenation may not be complete. The coagulation system is important. And as you increase flow to try to improve oxygenation, the coagulation system can be more difficult to deal with. CO2 removal is much easier. Substantial CO2 removal even at lower flows. And this, of course, has led to the interest in what we call extracorporeal CO2 removal, which is really flows through the oxygenator that are quite low, down in the 250, 500 mLs per minute range, dialysis level flows. And these are being looked at. But again, I want to emphasize these are really good at CO2 removal, but not particularly good at oxygenation. This is the biggest trial done on ECMO in severe ARDS. It was terminated early because of futility. That was very unfortunate because the futility rules were quite stringent. That is to say, if you weren't seeing a 20% improvement in mortality, the trial would be ended, and they didn't reach 20% improvement. But the trial was ended by the rules of the trial. So we end up with this, what I've heard other people call the most positive negative trial ever. And indeed, subgroup analysis brings out that ECMO probably did offer significant benefit. I think this trial is more supportive than it is negative in this severe population, and ECMO is an appropriate next step. Okay, now I want to move on to my caveats in COVID-19. I want to touch on 2 points. Number one is this concept that there are ARDS phenotypes when in managing this disease. And then I want to touch on implications for PEEP management. So this idea of hypoinflammatory and hyperinflammatory ARDS has been around a couple of years. On the horizontal axis here are a number of inflammatory cytokines. And as you can see, there's a pattern, the red line of what we call phenotype number 2, which is hyperinflammatory, and pattern number 1, which is the blue line, hypoinflammatory. And this is more than just biochemical interest. The blue line, the hypoinflammatory type, has markedly better compliance and actually doesn't respond to PEEP nearly as well, and actually benefits by using, I don't want to say flood the lungs, but fluid restriction is not nearly as important in this phenotype. In contrast, the red line, the type 2 hyperinflammatory, is characterized by much worse compliance, does need a lot of PEEP, and does benefit from restricted fluids. So why am I showing you this? It's because there appears to be, as we hear reports out of Italy in particular, that in fact the COVID inflammation of the lungs actually does manifest as both of these phenotypes. And that's important not only in terms of management, but also in terms of outcome. These are you'll notice if you're a hypoinflammatory type, your mortality is markedly better, your ventilator-free days are markedly better. So why am I showing you this? Well, because I think it does have implications for PEEP. And I put a little asterisk here because these are my opinions as of today. And I told Talal before we started this presentation that I may change this tomorrow for all I know as I learn more about this. So again, if you have the hypoinflammatory type, the infiltrates are not quite as extensive. If you measure a driving pressure, it's low, reflecting significantly better compliance when using a sort of standard tidal volume and a modest level of PEEP. And under these conditions, because they're not really PEEP responsive and because their compliance is pretty good, you probably should use the low PEEP FiO2 table, the low PEEP FiO2 table. Proning probably doesn't help as much here. And there's a lot of consideration, but absolutely zero data that suggests that if you are severely hypoxemic and have this phenotype, because PEEP and proning is not going to be particularly helpful, this may suggest more vascular involvement and perhaps a role for vasodilators such as nitric oxide. I don't want to recommend that strongly because I don't have a lot of data, but at least conceptually, that might be a place you might consider it. In contrast, if you have the hyperinflammatory state, more infiltrates, a stiffer lung with a higher drive pressure under modest settings, then I would use the more traditional PEEP FiO2 tables. And if your P to F ratio is low enough, actually use the high PEEP tables. In this patient population, proning does look like it has more effect, and fluid restriction is probably a more important consideration here. Again, these are my considerations today. We in North Carolina have not seen a lot of respiratory failure as yet. And like I said, as time goes by and we get more experience with this, we may, in fact, we likely will be changing recommendations as we go along. But at least at the present time, this is a strategy that makes some sense to me and kind of jives with some of the ideas Gattinoni has been sharing out of Italy regarding these two different phenotypes and the use of different PEEP and proning strategies in these two different phenotypes. So I've tried to cover a lot here. The basic principles, again, are to minimize static and dynamic stress and strain at end inspiration, during the tidal breath, and at end expiration. Proning, I think, has a role. I think neuromuscular blockers have a role in selected patients with high oxygen consumption, severe hypoxemia, and difficult to synchronize or fighting the ventilator. ECMO, I think, is reasonable in this population for those who have failed all the steps above. As I say, as we learn more and more about the COVID ARDS pneumonia picture, this immersion of these two phenotypes may take on an increasing importance as we, as I say, as we gain experience in managing this disease. So Talal, I'm going to stop there and wish you all the best and hope these principles will be helpful. And like I said to Talal, we probably will be updating this presentation as time goes by. Thank you all.
Thank you, Neil, for very enlightening talk. And I think we needed this refresher about basics and what we have to fight this pandemic. Thank you very much.